Right. Thank you very much, organizing committee, Dr. Sparias, Dr. Patakos, for inviting me to give this lecture about the topic that we did together a few months ago. I'm very fortunate to belong to the heart team of IGEA, or work closely with the heart team of IGEA as an attending surgeon in the second cardiac surgery department. So our pride is the hybrid OR at the IGEA hostel, which is probably the only one in Greece, or the only one working for so long, all these years. And why this is necessary, it's going to be shown in the case that I'm going to tell you about. It was an 83-year-old female with a very small stature and severe symptomatic and decompensated aortic stenosis. Unfortunately, she came to the doctors, to the surgeons, very late, as most of the patients do in Greece. She had a very bad past medical history, as you can see, with all the risk factors, etc. Her coronary angio was insignificant, and her logistic Euroscore was about 40%. The problem with this patient was that she had very, very severe peripheral vascular disease, and as you can see from the three-mention report, we literally didn't have much of choices for access. Both femorals were hostile to transcatheter passage of the valve that we wanted to implant to her, and the same happened with the subclavian access. She had stenosis, severe stenosis everywhere, including the abdominal aorta with a 90% stenosis. However, we went through our normal routine, and we started an attempt of a transfemoral approach, which soon became futile. And then, because we had the advent of the hybrid OR, we were able to swiftly convert to general anesthesia and open, let's say, access. The only two options we had were transapical and transaortic. We chose transaortic for arrangements that were previously done with the valve that we had to use, and that would be a Medtronic. As we all know, Medtronic cannot go transapical, so really the only option we had was a transaortic access. So that's what we did. We converted to an open, let's say, access with J sternotomy on the fourth right intercostal space. And then after having done all the previous wire things with a pigtail catheter, etc., from the left femoral side and the venous pacemaker, etc., we did a pericardiotomy, and then we entered the ascending aorta, which also we had previously calculated the length, and it was suitable enough to accommodate an Evolute 26R sheath. So the procedure went out without any difficulties or pitfalls. It was all planned from the beginning, down to every detail. We can see all the images from her angiogram and the initial catheters that we used from the left femoral side. We can appreciate how difficult the vascular access was from her femorals. We again validated our measurements about the length of the ascending aorta with the catheter lengths that we have here. And we proceeded with the transaortic access that I already told you. This is the Medtronic Evolut-R, the test we do in every valve because before we proceed with the implantation, which is mandatory, as we all know. And this is the deployment of the valve at the right height, about 3 to 5 millimeters below the annulus level. And this is the end result with no regards. We also did the transesophageal echocardiogram because now the patient is under general anesthesia. And we also validated that our valve was positioned well, and we had no regards whatsoever. This is the final incision, about 5 to 6 centimeters, 6 centimeters of the patient. And the reason I showed this case is that, as we know, with lower profile sheaths and delivery systems, most of the TAVIs are now done transfemoral, and this is the way it should be. But there is 1 or 2% of cases that need to have surgical access, could be transapical or transaortic, and every group who does TAVIs have to have these options available, ideally in a hybrid OR environment. So again, thank you very much for your attention.
Are there any comments for the audience? Or yeah. Mr. Patakos?
I think it's a very nice case, Konstantinos. Of course, I'm biased because I was there. But what I have to say is that I think it's important for every center to see what their comfort is with alternative access, because the 90-something% of cases are going to be transfemoral, but it's important to have a plan when you don't do transfemoral, where are you going to go to next? So I think because you and I were both trained as aortic surgeons in the US, I think transaortic is a nice second option. I think some other centers have a transsubclavian done percutaneously with ProGlide. But I think, as you and I have both seen, the subclavian is very friable. So if it goes well, you're good. But then if there's any issue and you have to cut down, the subclavian artery is very problematic. That's why when we use it in cardiac surgery for cannulation, for going on cardiopulmonary bypass, we usually sew a graft so that the cannulas do not go directly in the artery, because we don't want to touch the artery. The other thing I've seen is, if you do it transsubclavian, you have to be very careful if a patient has prior surgery and they have a patent Lima to LAD anastomosis, because I witnessed a case in Houston where they put a large sheath subclavian, cut off all the blood flow to the mammary, and the patient immediately arrested and died, and there was no time to do anything else. So I think today we've seen Marcus Cassell show us transcaval. We've talked about transsubclavian. There's transcarotid. You can do whatever you want, but I think it's important for every center to have what they want. And when we talked about this with Kostas Sparias, I said I like the aorta because if there's any problems, we can throw the whole thing in the trash and replace it. And I say it jokingly, but truthfully, if there's any issues, usually it's easier to fix than one would imagine. Thank you.
Totally agree with you. Yeah.
A question, please. Why did you prefer to proceed transaortic and not transapical
Thank you
using
for the question.
a sapien?
I mentioned that, but maybe I was not very clear. We had done some arrangements before the operation with which valve we had to proceed. So the valve that we had chosen was the Medtronic, and the Medtronic cannot go transapical. So our only option was transaortic, and provided that we could accommodate the sheath to the length of the ascending aorta. And since that requirement was met, we were left with only this option.
Yes. The problem is the mini sternotomy.
Mini sternotomy is a great incision.
Dr. Sparias?
Yeah.
Just a comment on the valve selection here. The valve selection here was a self-expandable valve because there was extreme calcification. If you notice on the angiography, it was very evident on the aortic root, the aortic annulus, the aortic leaflet, so we didn't want to go and expand the sapien valve there. Of course, if we had been successful from the leg, because we tried, then I would be more balanced in the valve decision. But since we left the leg alone and went from above, then I think a self-expanding valve here will be safer. And it worked very well.
I think if I can make a very quick more comment, even if we had Edwards valve to use here, or if we didn't have these issues, we wanted to use an Edwards valve, I'm a strong proponent that I think transapical should be absolutely the last route that we use, only as a last-ditch effort, and all the others should come before because of the size of the incision of the LV, the trouble that you can get into. And I think most cardiac surgeons will tell you that if you have an issue with the aorta, it's easy to repair. As I said, you can throw the aorta in the garbage and replace it, but you cannot do the same with the LV. So I've seen LV pseudoaneurysms, not here, but when I was in the United States. If you have an LV pseudoaneurysm, that's a really bad, that's a contained rupture, and it happens more often than you would think. So I think for technical reasons.
Can we ask if Dr. Pittis agrees with this approach, transapical versus transaortic?
Yes, I mean, most of the times I would very much have, until now, I would very much prefer the transapical approach because we've been using the transapical approach ever since 2008, and we never had a patient, an issue with the transapical approach. But having said that, we used to implant Zarifis in the apex. So we are used to take deep sutures and, okay, I mean, if you take superficial sutures, then, okay, yes, you're going to have a pseudoaneurysm. In this case, probably it is better to do the transaortic, but...
But I think the difference also in incision, no difference. They're not, the other one is the thoracotomy. And if you ask the patients, I think the thoracotomy hurts more. I don't know what your viewpoint is, but anyway, we don't have to debate it all night, but both of them are big thoracic incisions.
I have two questions. It's obvious that this procedure is rare. In EE experience, the last year or the last 2 years, in how many patients you have proceeded with this access? Well, and the second is, are there any preference referring the type valves, or any valve can be implanted transaortically?
So, thank you for your question. Obviously, Dr. Spiliotopoulos is the right person to answer this question. It's very rare that he uses open approaches. He has like a record percentage of 99.9% of transfemoral, and that's good.
No, I think every now and then we have a case like this. This is a typical case. We thought that we had good chances to do it from the leg. And if you notice, the angiographic appearance was not forbidding. Only when you see the CT scan screening, you get disappointed, because the angiographic appearance when we start the procedure was promising, but the MSAT always wins at the end. So then probably we do, I don't know if Dr. Bouboulis
Dr. Bouboulis is here, and he can also.
Once every 2 or 3 months, we have to go directly from above, from another access. So it's about, it's certainly not more than 5% of the cases we're doing.
Having said that, I have to say that I have, familiarity with both accesses, mini sternotomy and transapical. From my training in the US and Canada, I have done quite a few transapicals myself, and mini sternotomies. It's an easy incision for me. I wouldn't, have any problem doing that. But I totally agree that if you can avoid it, it's better to go transfemoral, as we do.